Very good morning, and I greet you in the awesome name of my Lord and Savior Jesus Christ. Welcome to our 16th Mnemonic and Untitled Medicine, this time breaking down an easy way to remember management of heart failure. There was once an American who had a heart attack while vacationing down under in Australia. Now, when he comes to the hospital, the nurse walks in and the man, still confused, asks, "Did you bring me here to die?" The nurse replies, "No, mate, they brought you in here yesterday." So when we're speaking to acute management of heart failure, just remember your CABs, so circulation, airway, breathing. If the patient's hypoxic, you want to give the patient oxygen to maintain a saturation above 95%. Right? And then in terms of the acute management, in terms of symptom control, we've got to give some Lasix. So you can go up to a ceiling dose of 120 milligrams IV PRN, but you want to look at your blood pressure. You don't want to drop your blood pressure too much. Morphine, as we know, is a vasodilator and an anxiolytic. You can go 2 to 5 milligrams IV when necessary. Nitroglycerin as well as a vasodilator. 0.4 milligrams sublingual PRN. Oxygen you can give as well if the patient's hypoxic, we mentioned, and position. You want to position the patient upright to ensure proper oxygenation of the lungs to negate the effect of gravity on pulmonary edema. Then long-term management, guys, we speak to D for diet. So low salt diet, ideally below 100 millimoles of salt per day, which equates to about below 1.5 to a max of 2 grams per day. And fluid restriction, ideally 1.5 to max 2 liters per day. Then in terms of diuretics, you can give Lasix chronically with daily adjustments, and try to use the smallest dose possible to allow an ACE inhibitor as well. You can also give spironolactone at 12.5 to a ceiling dose of 50 milligrams per day. Then D also stands for vasodilators, all right? So to this end, we speak to ACE inhibition. We commonly use enalapril, but there's others out there like captopril, ramipril, lisinopril, perindopril. And angiotensin receptor blockers as well, if the patient is intolerant to the ACE inhibition because of bradykinin-mediated cough, so there we can use valsartan or candesartan. If the patient has renal failure, you can use hydralazine nitrates as well. Beta blockers are also a good idea. That all comes under D. Then digoxin at a dose of 0.0625 to 0.25 milligrams daily per us. But remember, DIG doesn't portend a mortality benefit. It just prevents readmissions and is good for morbidity, but not for mortality. And then ideally, you want to treat the underlying cause. If you have coronary artery disease, you're going to get a PCI for the patient, which is percutaneous coronary intervention, or get the patient a coronary artery bypass graft. If the patient has aortic stenosis, you want to replace the aortic valve. If the patient has sleep apnea, you want to get some CPAP for that patient. Then lastly, devices. So if your ejection fraction is between 30 and 35%, you can consider CRT, which is cardiac resynchronization therapy, or biventricular pacing, with or without an implantable cardioverter defibrillator. Ventricular assist devices may also be considered in select cases of refractory heart failure. Now, in terms of the drugs that confer mortality benefit, we know that in the situation of reduced ejection fraction, which is ejection fraction below 40%, certain medications do indeed have mortality benefit. And that's where we speak about our ACE inhibitors, and our ARBs, which is angiotensin receptor blockers, beta blockers, mineralocorticoid receptor antagonists, which is spironolactone. And the new kids in the block, of course, is the angiotensin receptor neprilysin inhibitors. So in patients who have shown good response to an ACE inhibitor on ARB, we can allow a drug-free period of 48 to 72 hours, and then we can start our ARNIs. And the combination of sacubitril valsartan demonstrates a 16% reduction in all-cause mortality and a 20% reduction in death from cardiovascular causes and 21% reduction in heart failure hospitalizations in comparison to enalapril. So actually, it does trump enalapril. So the overall approach, guys, in treating heart failure is you want to treat the underlying cause if possible. Non-pharmacological treatments must be used, like diet, exercise, smoking cessation. And to that, you can add ACE inhibitors if the left ventricular ejection fraction is below 40%, or if there's concomitant renal failure, you can use hydralazine or nitrates, use an ARB if there's cough secondary to an ACE inhibitor. To that, you can add a beta blocker when the patient's euvolemic, especially if the left ventricular ejection fraction is below 40%. Then to that, you can add spironolactone or eplerenone if the patient has NYHA grade 2 to 4 dyspnea. And if the left ventricular ejection fraction is below 30%, you can use digoxin and ARB if still symptomatic. And then you thereafter consider devices like cardiac resynchronization, implantable cardioverter defibrillator, and ventricular assist device, and lastly, heart transplant. Whew, this was a mouthful. God bless you, and I hope this benefits you. I'll catch you tomorrow with another beautiful mnemonic and internal medicine. God bless you.